Thanks everyone for coming to the seminar this week. Alice Chen is joining us from the University of Southern California. She's at the Sol Price School of Public Policy and is also affiliated with the Schaefer Center for Health Policy and Economics. Alice is a health economist and labor economist. She got her PhD in business economics from the University of Chicago. She's published in leading field journals and general journals, the American Economic Journal, the Journal of Health Economics, Journal of Policy Analysis and Management. She's fantastic. So we're lucky to have her here today to present her paper on physician fraud deterrence. Thanks for being here.
Thank you, Jeff. I'm very happy to be here and see a seminar so well attended, so thanks all for showing up. Having been from Chicago, I'm very used to people interjecting, and so definitely feel free to interject with questions, clarifications, complaints, arguments, what be it. So that's pretty much all I got. This is a paper that's joint with Yoonhae Shin, who's a PhD student of mine at the economics department. She's on the market this year, and she's fantastic. And also Babu Jena at Harvard Medical School. Okay, this is my obligatory acknowledgement of NIH. Thank you, NIH, to the camera. Now it's officially recorded. Just to acknowledge some grant funding. Okay, so really, the motivation for this paper is to think about all of healthcare spending in the U.S. is a big chunk of money, as you may well know. Much of it is accurate, some of it is fraudulent. We don't actually really know how much of it is fraudulent, but people have tried to estimate exactly how much that is. So, 2016 there was about 4 billion health insurance claims that were filed. Some of this is through private health insurance, some of it's through public health insurance. And most of it is probably legitimate. So essentially, these are services that physicians actually provided to patients who actually needed them, right? But some of it wasn't, and the Institute of Medicine estimates that sort of this amount of fraud, waste, and abuse is roughly around $750 billion, which is essentially 28% of healthcare spending, and that's a lot of money that is just wasted. And then, what about fraud itself? Well, the FBI thinks it's about $80 to $257 billion, so essentially about 3 to 10% of healthcare spending. That estimate's it's a pretty wide range, but that's sort of the best that they could do. Of that waste, the Department of Justice recovers about $2.5 billion. So as you can see, a lot of money has left the government. Essentially, much of this is all. Well, not these estimates, but what I will be looking at is sort of publicly funded insurances. So essentially this is like taxpayer dollars that has been used and wasted on services that were not actually ever provided.
How much is spent on trying to detect fraud?
It's a great question. I don't have the exact answer for it, but I do have some answers coming up. So like the ACA spent $353 million. The Small Business Act spent $953 million. These are all over like a 10-year period. This is essentially from the government. The yearly budget, I'm not exactly sure, but we could sort of back it out if I could do math on the spot. But the estimate is that for every dollar spent on fraud, there's $4 recovered. So if you can kind of back it out from your 2.5 billion. So yeah, so a lot of money, but not nearly on the order of these dollar values. Fraud is a growing problem, and I think this is true particularly among publicly insured companies, public insurance in particular. So, think with private insurance, private companies they pay attention a little bit more to where their dollar is going. So they have gatekeeping where if you want to see a specialist, you have to get approval first, and their claims, if it's bad, essentially bad billing, they just won't pay it out, whereas Medicare pays it and then tries to get it back, which seems very inefficient. Right, so essentially fraud is sort of a bigger problem, we think, in publicly insured programs, which is what we'll be looking at. Okay, so how this fits in is sort of, we have a large literature on the economics of crime and the effects of deterrence. So there's a lot of things looking at how incarceration, laws, and policing affects the amount of crime that one observes. And this is sort of related to that. And the difference here is that in healthcare, crime is more difficult to detect, right? And if you think about like property crime or violent crime, it's pretty clear when that has happened. In healthcare, the claim is that, oh, well, these people are providing services that are unnecessary, that shouldn't be provided. But because of the asymmetric information, patients then, or physicians then claim, well, like, you know, patients actually needed this. How do you prove that my patients are just very severe conditions? How do you prove that they didn't need that extra MRI scan or that extra imaging test, right? And so it's harder to detect crime here. And so in that sense, I think having a value of deterrence in healthcare is valuable. Any sort of deterrence in the healthcare world has focused on malpractice liability. So thinking about how physicians are being held accountable for doing bad behavior. And what they found is sort of the effects of deterrence really depends on what types of reforms are being passed. So the nuances of malpractice reform, depending on if it's like the penalty increasing, or like the number of, you know, how much malpractice insurance is, right? So there's a lot of nuances in malpractice liability that has led the results to be quite mixed. So some effects, some people find some effects, some people find no effects. What we're doing here is related, though arguably quite different, which is to look at physician fraud. And to the best of my knowledge, I don't think there's anything out there on physician fraud per se. And so what we're going to do is measure the direct effect of sort of sanctions on fraud, waste, and abuse on how people who look like they're fraudulent but haven't been caught, what is the effect on their behavior? Okay. So as I mentioned, this is the return on investment that the healthcare fraud and abuse control program quotes, which is essentially on average $1 spent leads to $4.20 recovered, which is a pretty good return on investment. But my claim here actually is that what they're doing is finding the most egregious levels of fraud. So essentially, they find the people who are committing like billions or millions of dollars of fraud, and of course they're going to get a high return rate, and it's also easier to catch them, so the cost is much lower. Now, if you really want to get rid of this like $80 billion fraud estimate that we have, it's gonna get harder and harder. So to the extent that you can encourage some sort of deterrence effect, it would be good to know. Otherwise, you're going to be spending that sort of gap between $1 to $4.20 will be decreasing. So as if it's not already clear, we're looking at the deterrence effects from sanctions of fraud and health crimes. And improper prescribing, I'll talk a little bit about, but we're not going to focus on it today.
How fine is the line, just in terms of fraud detection, between sort of what the feds determine is fraud versus defensive medicine or something? Tell me about the line.
Yeah, you'll come to discover in a couple of slides that it's pretty clear, almost like obviously clear, that these guys are fraudulent in that if you're billing Medicare per physician over $1 million a year, you're likely not doing defensive medicine. That line between defensive medicine and possibly fraudulent is very fuzzy. And I don't think people have quite figured it out yet. And in fact, even in our estimates that we'll see when we see reductions in, just as a precursor, we find deterrence effects. And it's unclear what that's coming from, if that's sort of, oh, we're just going to do less defensive medicine, or if it's really we're like reducing waste, right? It's unclear where that is coming from. Worth exploring, though. I think I haven't thought carefully about how one would differentiate between those, but yeah. So I'll spend a little bit of time talking about who these excluded providers are. This is essentially the variation that we'll be using, which is providers who are excluded from Medicare and Medicaid because they have been fraudulent. And I'm going to use the word fraud as some basic blanket for like fraudulent behavior and bad behavior, health crimes. It's not necessarily all fraud, but I'm just using that so you don't hear me say fraud, waste, and abuse every time. I mean so every time I say fraud, I mean fraud, waste, and abuse. We'll talk a little bit about the excluded providers. I'll try to get through that somewhat quickly because it really is just sort of background to tell you about the variation. And then we'll talk about sort of what we think should happen, the data, and what we actually found. Okay, so the way this works is the Office of Inspector General, which is under the Department of Health and Human Services, is an organization that essentially is allowed to pick providers off of Medicare and Medicaid. Medicare being essentially insurance for those over 65, and Medicaid being is the insurance for poor, low-income individuals. And so they are tasked with, under the Social Security Act, they're tasked with identifying and excluding providers who have committed healthcare fraud, health crimes, or abuse of controlled substances. And I'll give you examples of all of those on the next slide. And essentially, exclusion means that you can't see any publicly insured patients. So you can't see a Medicare patient, and it's really difficult to for a hospital to hire a provider who can't see any Medicare patients. In theory, they could still see privately insured patients, but as you might notice, these are people who are likely to have their licenses rescinded at some point in time too. We think that there should be an effect within the organization because organizations are responsible for knowing if they are billing Medicare for a fraudulent provider, right? So if a provider has been excluded from Medicare, okay, excluded, and then say the hospital then bills as if the provider had provided a Medicare service, not only are they not compensated for that service, they're then slapped with a fee, fine, penalty. Yeah.
Are there considerations from the Office of the Inspector General on kind of the number of other providers in a particular area? I mean, I can imagine in rural areas you don't have many options. You kick someone off of being able to serve, low-income or elderly patients. That could be a big burden for the patients themselves. Is that at all a consideration that you've come across, or is it not really? Is there enough competition that shouldn't be a concern?
It is not a consideration. So if they kick someone out and it happens to be in an area where that is like the single provider for a certain area, then the patients are sort of out of luck, really. This is actually, the patient analysis, I think, is one that is also very interesting, which I haven't done in this paper. Looking at what happens to beneficiaries whose providers got kicked out, where do they go? And you'll see that we see the sort of patients drop, the number of patients per provider, even amongst the non-kicked out providers, so the ones that are still operating. You see patients leaving there, and it's actually unclear to me so far if there's just less use of healthcare or if patients are going really further outside. And I'll show some evidence that the patients are sort of are leaving not only that organization where there was a fraudulent provider, but also outside of their zip code. Any organization within their zip code also shows some both deterrence effects and drop in patient count. So if they're leaving for somewhere even further out. Yeah.
Given the potential exposure of the organizations to these civil penalties, is there any kind of proactive auditing that's happening? Like sort of an internal audit before the OIG gets involved or anything there?
Yeah, so I think these are going essentially to mechanisms on like what is controlling fraudulent behavior, and not to my knowledge. I mean, it's possible. I actually don't really know how much is going on internally. Some of these cases, it's like the CEO who is being excluded, and so in that sense, I think it's like the head of the organization is just not paying attention or thinking that they can get away with it. It turns out that these exclusions are very, very low probability events, and so in some sense, that doesn't incentivize auditing or even behaving well. Yeah.
So, just out of curiosity, are the majority of the providers committing fraud in like private healthcare groups, or is it also happening in so when I lived in LA, I had Medicaid for just the LA County, the USC hospital.
Sure.
Is it also happening in those publicly funded sorts of settings, or is it primarily in the private sector?
So we can't observe fraud that's happening in the private sector.
Oh, okay.
So I don't know. I imagine it's less precisely because it's harder to defraud the private sector.
Well, say you have a provider who accepts Medicaid, but they're not attached to a hospital or a group like that. Does that also?
That definitely also occurs. So if it's a provider, in a single provider office, it happens across all different types of settings. So both your large hospitals, whether it's a high quality hospital or a bad quality hospital, and your small office settings, essentially. Great question. And I'll show you a graph that sort of looks at the distribution of organizations. Okay. So here's some reasons for exclusion. So fraud are things like submitting false claims, so billing for things you didn't actually even do, billing for services not rendered. Submitting false claims is essentially you might bill for a service that is more intensive than the one you actually provided. Unbundling services, so there's some payments in Medicare and Medicaid that you're supposed to do like a whole bunch of services for, like, say, hip replacements, but yet you charge for each service that you do instead. Misrepresenting dates and times. Health crimes is essentially provision of medically unnecessary procedures. So there's a story I heard about, like, an ophthalmologist doing cataract surgery on every person who walked in, regardless of whether they had a cataract or not. That would be health crime. Identity theft, so this is like pretending like you're a doctor when you're not even licensed, you just like steal someone's identity. Patient abuse is in there too. Oftentimes health crime and fraud, these categories sort of blend a little bit, but they're defined based on whatever is the reason that's provided as the main reason for exclusion. Substance abuse, I've sort of put in parentheses here, but it's essentially like illegal distribution and prescription of controlled substances like opioids and surgical anesthetics. And we're not looking at it here because we're not looking at the prescription claims data, but it's something that we are thinking about doing next. Okay, so here's some even more examples. This is September 29th, 2017. Former executive of Tenet. Tenet is a very large hospital chain in the US, charged with clinic owner and operator in a $400 million fraud and bribery scheme. Here's another one, doctor convicted of $50 million, Medicare fraud scheme, sentenced to 200 months in prison. So he ends up having to pay Medicare back $34 million, which probably he won't, but it's a not even the full share of the $50 million that he ended up defrauding Medicare with. And just to show you that they're not all crazy schemes, here's one where a podiatrist pays $35,000 to settle some allegations. Okay, so like some misdemeanors also exist in the data set in addition to your large felonies. Okay, exclusions have been rising over time. This rise here, sort of, it seems like everything starts taking off around 2010, after 2010. This is 2011 essentially. The red line looks at all exclusions, and the other three lines on the bottom here look at different types of exclusions. Yes?
I was just going to ask you quick. Once the provider is excluded, can they earn the right back in to be unexcluded?
They can't earn it, but they can be given, like if their exclusion wasn't too egregious, if their crime wasn't too bad, they can be reinstated, yes, yeah. So like the misdemeanor, like that felony case, the guy probably was excluded for 3 years and then earned the right to be back. Some other times it's 10 years, other times it's permanent. Great question. So as you can see here, the substance abuse that we're ignoring is actually really like a small share of exclusions over time. And you know, we think that like the exclusions have been increasing pretty much because we dumped a whole bunch of money into trying to detect fraud. This gives you a sense of exactly sort of the geographic variation, looking at what share of physicians have been excluded. So here we're thinking about, this is in the thousands, so it's essentially 3 to 5 physicians per 1,000 have been excluded over the last 10 years. Okay, so it's essentially, if you want to divide this, it's like 3 per 10,000 a year is on average what's happening. So it's really not that many. There is some variation, and the variation sort of corresponds to where they've put these so-called Medicare and Medicaid strike forces or controlled fraud control units. And so the yellow dots indicate where the Medicare fraud control units are. Tends to correspond, not perfectly, but in general to like the darker states which have higher rates of exclusion. Of course, Florida here is one of the big hot areas. To give you a sense of what types of doctors are being excluded, this is just looking at the odds ratios. Apologies for the comment. We ended up sending this to a medical journal, hence why the odds ratios. But so anything greater than 1 is essentially like a higher odds. And looking at sort of characteristics of the exclusions, and they tend to be sort of more foreign trained doctors, more male, definitely older doctors. And within sort of family practice, psychiatry are sort of the big types of docs being excluded. Okay, so I think that sort of So one more graph, just sum up exactly the variation that we're looking at. This is going back to your question, looking at the types of organizations. It doesn't have precisely like place of setting, but it has organization size, so essentially the number of unique physicians in an organization. And you can see that they range from like your small, individually owned practices all the way to your large hospitals at the tail end here. Okay. So getting to the conceptual framework, so what do you think would happen when a physician is excluded? Well, you really hope, I should actually rearrange these, but starting with the non-fraudulent providers, you really hope that there's really nothing, like no effect going on. If you're not doing anything wrong and someone gets caught, why would you care, right? So I think that's one argument that can be made. The other argument is that, well, someone gets excluded from the organization, now you have a shortage of labor. So if the patients keep on coming back and they want to see, say, Dr. X, who is excluded for fraud, you say, well, Dr. X is no longer with us, but you can see Dr. Y, then you might see an increase, if anything, an increase in say, supply and charges and claims. Okay, so that's what we expect. For the fraudulent providers, you would hope to see something different. For the fraudulent providers, if there is any deterrence effect, you would see a drop in claims and charges. Maybe there's no effect either, which would then mean that either they don't care, which is maybe plausible given the low probability of a bad event or a low probability of being caught, or that we sort of miss the window and we just like haven't figured out exactly what's the right date in which to measure a response. Okay. I'm going to try pretty hard to convince you that we kind of have the right date. We have dates on exclusion, and we anticipate that responses happen when the provider is caught, which is very different than the time in which the providers are excluded. Okay? So essentially this process is either you're indicted or arrested, okay? And we're treating them as like, they're not the same, but there's similar time frames in the sample in particular. There's very few incidences where like the police go like breaking into a physician's office to arrest people. So arrest and indictment, I think, are pretty similar time frames. You either plead guilty or you're convicted at trial. Most people plead guilty. There's about, of these two, relatively speaking, pleading guilty is about like 85% of the sample. Okay. Then you're sentenced and then you're excluded, right? So there is actually a process that's going on before you're actually officially excluded. And you're excluded if you receive, say, a felony or misdemeanor conviction. There's, of course, some subset of people who nothing happened to them, so the case was dismissed or they were found innocent. It's about 24% of the sample. So what we have is data on the physicians who are excluded. We have their names and the exact dates of exclusion. Okay? And we look at, this database is actually pretty old, but we look at 2005 to 2013 for a reason I'll tell you, because we want to allow for a long pre-period in order to make sure that we catch any anticipatory effects. In our Medicare claims data, which is the next data set I'll talk about, the earliest year we have is 2002. Okay, so we essentially start looking at exclusions where we have at least a 3-year pre-period sample. Okay? So 2005 to 2013, and we essentially take these names, mash them to identifiers, and focus only on the physicians in the sample, not like the owners and the CEOs, which would be an interesting, I think, different paper, just not this one, and use the date of exclusion as a benchmark. And then what we did is, in order to figure out when sort of the relationship between date of exclusion and date of indictment, we went and did a whole bunch of web text searches, and this is somewhat still work in progress. So we've scraped some of the website and found some of the dates. I don't think we're going to be able to find all of the dates for all of the providers. It's just not a well-kept database. And this is what we've come up with. Okay, so those who have a guilty plea are on the top, and we look at essentially the dates of the plea relative to, the dates of the indictment, the dates of the pleading, sentencing, and exclusion. Right? So we try to map out that diagram that I showed you earlier. And we do it also for the ones who go to trial. So the guys who pleaded guilty and the ones who are convicted to be guilty. And you can sort of see, the point I want to make here is in the last column, the time, and these are reported in years. So the time from being indicted to excluded is roughly about 2 to like 1.5 years. Okay, so. And that's true whether you pleaded guilty or you were convicted at trial. Okay. So that's what we have. And then the other main data set that we're using is essentially data on providers and the types of services that they're providing. So we're using 20% Medicare claims data from 2002 to 2014. And this is very detailed data for those who are interested in health economics and want to use it. I encourage you to apply early since it takes forever to get approved, but they will approve projects, it just takes a long time. Essentially what it does is it reports each service that was a detailed claims level information on the service that was provided by which provider for which patient on which date. And so they have essentially provider information. They also have TINs, so NPIs you don't need to follow all of these jargons, but like provider IDs. TINs are essentially tax ID numbers and they identify organizations. So they have the organization IDs, physician specialty, place of service, which will be like a hospital versus an office setting. Zip code, they have patient age, gender, race, and so it's very detailed data, which we then look at the physician quarter year level. And essentially what we're going to do is look at only physicians in organizations where there was an exclusion, which is, it just drops a lot of the sample. There's a lot of other organizations that we can look at. The reason why we don't do like a diff type of approach where we look at organizations that were excluded relative to organizations that didn't have an exclusion is because we're treating the exogenous variation that we're looking at is essentially the date in which a fraudulent provider is caught. Okay, so we're treating that date as plausibly exogenous. And you'll also see there's really no pre-trend, so in that sense, if there's no change in behavior in the pre-trend, we don't really need to control for anything. We have actually looked at a matched sample where we match physicians in an excluded organization to physicians in organizations with no exclusions, and the results are very similar. What this also means is that if essentially an entire organization of physicians is excluded, then that gets dropped out of the sample since there is no pure effect that we can then measure. And that happens about 8% of the time.
How long is the typical sort of investigation period and how public is it?
I do not know how long that investigation period is. It's not supposed to be public information. I haven't seen any press releases about it. The DOJ hasn't released anything about the investigation happening. I only see information on indictments. Though it does appear that at least when the investigation is ongoing, they look at a very long time frame in which providers have been fraudulent. So I think the past is definitely taken into account. I don't know how long it takes them to do the investigation. Do you think that the effects are occurring prior to indictment?
Well, I mean, I know you can look at that.
Oh, yes, that's what
but I was just, yeah.
Yeah. Yeah, I mean, I think it would be good to have more information on this, though. I think the only things that comes from like reading these reports that the DOJ, actually the OIG releases annually. So, yeah.
Could you compare those that were indicted and ultimately arrested/excluded to those that were indicted but then not, either was dropped or found innocent? Maybe thinking it's more cleaner treatment control group to see the matchup there are those kind of like pre-actual exclusion effects happening, driving the result.
That's a great question. I think if we could do that, we would. The problem is, what you'll see actually here is like, at least in this sample right here, the numbers that we have are very low. So like, this is not representative of the number of exclusions that we have. So what we're doing is essentially tracking every single press release that's been given and trying to figure out when these dates are. And sometimes we have a date for like indictment, but we don't have a date for pleading or sentencing. It just never shows up, and it's organized by like month in which these activities occurred. So it's like a messy data process, which makes that difficult. But if we could do it, I think it would be a great exercise. Okay, so our approach essentially is to first have a predicted probability of who we think is an excluded provider. Okay, and then amongst those that we think is like, essentially what we're trying to do is predict who is possibly fraudulent in the remaining organization. And then we look at behaviors over time. So what we're going to do is to predict the probability of exclusion, which is essentially the probability of being fraudulent, using data in years sort of 3 and 4 prior to the date of exclusion. We're essentially going to run this logit model to look at essentially whether or not a provider is excluded based on observable characteristics in the data set. And these characteristics are things like total claims that are being filed, so essentially the number of services, you can think of it as that, number of charges, charges per patient, claims per patient, number of patients, right? And so those are the observables that we have. We're also going to control for some physician observables, so like your specialty, we have some specialty dummies, we have place of service dummies, and then we have some time fixed effects. Okay. So we're going to try to predict this exclusion. And then after doing that, after figuring out who is likely to be fraudulent versus who is not likely to be fraudulent, we then look at behavior over time. Essentially, this is the sort of the more general or the less general version of an event study, just looking at what happens after date of exclusion relative to what happens before the date of exclusion, controlling for patient characteristics, physician fixed effects, and year-quarter fixed effects, right? So essentially, because the data is the physician quarter-year level, this is going to be looking at changes in behavior for a given physician over time. Okay, standard errors are clustered by the organization, and in order to allow for this sort of pre-period trend, we put the date of reference at the third quarter, year 3, quarter 1, prior to exclusion, in order to make sure we allow for at least 2 years prior to exclusion. Okay, so this is our predicted probability of exclusion. It's not as perfect as I wanted it to be, but I can't make the data say something that it's not going to say. So essentially what we did is look at the predicted probabilities of exclusion. You can see for the excluded providers, that's in the white bars, and the non-excluded providers in the gray bars. You know, when I say it's not exactly what I had hoped it to be, I meant that I would have hoped that we had very low, like there were no excluded providers with probability 0 of being excluded. Like you would have hoped that that was higher. And you know, it's certainly a lower part of the distribution, like fewer providers have that probability, but it still exists. So I feel like we haven't really predicted the left tail very well. And it could be that like there are other reasons other than the observed characteristics that we have for why those providers were being excluded. For example, I think like Medicare pays attention to whether the provider is getting kickbacks from other providers, and so I think that's sort of more unobservable in our sample. Yes.
Well, it's also such a rare event that someone gets excluded. That
yeah, so the other...
In some sense, you shouldn't be expecting this to be like a completely clean, kind of...
Beautiful.
Beautiful, yeah, bimodal distribution here and overlay that.
That's fair. So I mean, it's a low probability, and then maybe we just haven't, it's hard to predict well. Fair point. We have divided the sample just to give you a sense of like the distribution. The red lines correspond to the 25th, 75th, and 90th percentiles of the not excluded distribution. The blue lines correspond to the similar percentiles for the excluded distribution. And so if you look at this, I mean, I think it's pretty clear to assume that anyone with greater than 90th percentile predicted probability of exclusion is likely fraudulent. Right? Like these guys look like they have very high probabilities of being fraudulent. 75th, I mean, it's arguable whether you think these is like a really good prediction of fraudulent or not, but even for the 75th percentile guys, they fall they correspond to a pretty low distribution relative to the excluded probabilities, right? So like 75th is almost around the 25th percentile amongst the excluded providers. Okay. So essentially, we're going to look at the samples by those by these 3 groups: 0 to 50th percentile of predicted exclusions, 50 to 75th, and 75th and above. And these are defined; they're not just like one-off events. So we made sure that like these are sort of consistently high billers or consistently low billers by looking at grouping physicians into these groups if they've spent at least half the time, so at least a year in these categories. And the excluded physicians are in column 1. And so there's a couple of things that I want to point out. For the part, column 1 looks like column 4, right? So like predicted exclusions, 0.15 relative to 0.13, arguably similar. Charges per patient, charges per claim, claims per patient, right? This is arguably similar between columns 1 and 4. They're very different between columns 2 and 3, of course. These are guys who are just providing less charges and providing fewer services. And so for the most part, it looks fairly similar, except for the stuff that's highlighted in beige, right? That's just like completely different. For excluded providers, they have an average charge of $33,000, whereas even the most fraudulent-looking provider in our non-excluded sample only has about $1,000 of charges. What you'll see is that this is really driven by the number of patients that are being reported. And so I think one story, I don't have proof of this, but one story why that might be the case is there's stories about how physicians essentially waive the copay. There's a 20% copay on services, and they'll just waive it for patients and then just start charging and billing patients for services. I mean, essentially, like, once you go and you see your provider, they have all the information that they need to bill Medicare, right? Like, if you think about when you go and see a provider, you provide them with your health insurance, they have your health insurance, they have your identification, they can bill your health insurance company. And essentially, they'll waive any patient participation in this payment amount, and then they can just charge however they want to whomever they want, and no one will know the better. So I think that's sort of driven what we see here. Okay. But then to that extent, I think, this is sort of going to the argument where these guys are clearly fraudulent. These guys they seem to be fraudulent too, but less egregiously so, which makes them more difficult to catch.
I wonder, do you have the table of the coefficients on from that, the first stage? You do the predicted probabilities. I'd be curious to see kind of whether the coefficients that are highlighted in beige are the ones kind of load in that versus the ones that are not highlighted that look more similar to the 75th percentile. And that might tell you something about either kind of what the government is using to who they're looking at, but then it also might inform. It might tell you something about kind of what you're picking up when these predicted probabilities. If you're getting this variation in the predicted probabilities off of coefficients that aren't necessarily precisely estimated, or aren't particularly significant, versus the ones in beige that are really the standout characteristics, like the ones that get excluded.
I see. I don't have the table recorded. I can tell you that most of these, if all of these estimates are statistically significant, but some are more so than others. So some have t-stats of like 10, while others have t-stats of like 2. I think a way to get at what you're saying, instead of looking at the coefficients and whether they're significant or not, is actually to sequentially remove them from the model and compare how well the predicted probabilities turn out to be, to then see, well, what are the things that are actually really working in this sort of identification.
Right, or even with those two groupings, since the ones that are kind of starkly contrasted with the people who didn't get caught but who might be fraudulent, versus the ones that kind of look more similar. To kind of rerun it and see how much that changes your predicted probabilities.
And who's in which bin.
Right.
That's a great idea, and we should do it and see how it goes. Just to make sure it's somewhat robust. Yes.
So just back to Ryan's question, I'm wondering if you ever try some either non-parametric or semi-parametric technique to play out with those characteristics included.
We haven't. I mean, in theory, if you really wanted to go completely non-parametric, we could do a machine learning type of let's figure out which of these variables are more important in predicting, which we haven't done. I'm not sure what it'll turn out to be. My understanding of machine learning, which maybe others in this room can comment on, is that it actually makes a difference in some cases, but it's not all that. It doesn't make that big of a difference in most cases in terms of the results. But it would, I think, tell us which variables are more important than others.
And like logit regressions are a piece of that, like many of those algorithms anyway, so you're like part of the way there already.
So yeah. I'll just claim this is machine learning. that works just fine. That maybe we can take on camera. Anyway, Most of the other variables look pretty similar, so we're talking about like the patient characteristics. I didn't include all the covariates here, but patient characteristics are fairly similar between columns 1 and 4, even I think across most of the columns. The one thing that is pretty different, I think, is the office setting. So whether you're in an office-based setting or a hospital-based setting, 1 and 4 look very similar, but say like 1 and 2 don't really look very similar. So a lot of the people in category 1 tend to be hospitals, whereas in the excluded physicians and the ones that we're claiming are likely fraudulent tend to be more in sort of smaller office-based settings. ACS is ambulatory surgical centers. It's sort of your outpatient hospital and nursing facilities. They're all very small shares. Yeah.
Does this only include like MDs and DOs, or does it also include PAs and nurse practitioners and all those sorts of?
So we've limited this to MDs and PAs. MDs and DOs. In the sample, there are some NPs and there are no NPs. We have some information on RNs. I'm not sure if PAs is like an available code in the Medicare specialty, but for now we're focusing just on physicians. And I've had some interesting conversations about sort of looking at like physicians and nurses.
Yeah, because we had a presenter, I think, last month who spoke about oversight for non-MDs and DOs, and so like one question would be whether you have MDs who have a lot of PAs and NPs under their supervision, whether they're fraudulently claiming a lot more like operations or money from people who like report to them, as opposed to like just things that they're doing. So.
Yeah, I mean, I think it's a great question. The way Medicare allows for billing is I think physicians get to bill for the entire portion, depending on how much supervision is provided for the other services, depending on state specificity and sometimes the type of service. NPs and PAs bill, actually NPs, I don't know about PAs, but NPs bill for 75% or 50% of the allowed amount. So in that case, since if you're really going to try to defraud Medicare, you should just bill under your physician's identifier, which I guess would be identity theft too, in addition to billing.
Didn't she talk about that?
I think,
that was something one of the findings of the papers. That,
Oh, yeah.
This is actually a really common practice that these people are billing under their position.
Someone else's, someone else's code, just to get more money into the organization. Okay, so I'm going to show you a series of graphs now looking at these 3 percentiles. This is essentially, the green lines are going to correspond to 0 to 50th percentile, the blue line 50th to 75th percentile, and the red line greater than 75th percentile. Year of exclusion is the x-axis, so right here is year 0. Right here we've marked sort of the 2-year pre-period, if you want to call it, which we think corresponds to the date of indictment, or roughly, plausibly, the date of indictment. We are using data right here, years 2 to 4, 3 to 4. I couldn't figure out if I should call this 2 to 4 or 3 to 4. This is really, I mean, it's not year 2 because 2 starts from here to here. It sort of goes backwards, so in some sense it's like years 3 to 4, although on the graph it looks like it's 2 to 4. This is sort of the period of time in which we're using to make those predictive probabilities. Okay, and of course this is going to be the reference point of 0. So yeah, I think it's pretty clear that there is a clear deterrence effect. So this is looking at the total charges per physician in a given quarter over time. And you can see there's not much of a pre-trend. I mean, I don't really know what's going on with this uppity dude over here, but really it's pretty flat, or arguably flat for the other two groups. And especially for the 50th to 75th percentile, they are consistently 0. And this is, it's unclear whether those guys are fraudulent or not. I mean, they may or may not be fraudulent. For the 75th percentile, we think they are more likely to be fraudulent, and we see a sort of big drop in changes, in total charges. The green lines, actually, if you squint, you'll notice that it's like slightly increasing and slightly positive. And that could be that they are taking they're accounting for changes from the fact that there was an excluded provider. And maybe, I don't know if you want to, there are possible stories which we haven't investigated. I'm not sure how many of these stories we can actually really get at, but there could be some sort of like change in patient allocation even within the firm, right? So you realize like doctors X, Y, and Z are fraudulent, but Dr. A and B look like they're sort of more in line with standard billing practices, and you start to direct patients to doctors A and B. So that could be another explanation. Okay, so that's total charges. This is total claims. So essentially, the outcomes we'll look at it are starting from the more aggregate level, then to the smaller intensive margins to try to figure out exactly what's going on. Total claims seem to show the same pattern. So the red lines are falling, blue and green are pretty flat. Green is very clearly around 0. So we know that they're charging less. We know that they're presumably doing less or claiming to do less. And this is true, it's not solely driven by changes in patients. So this is true even for patient-specific charges and claims, right? So this is now looking at charges per patient. Similar story here. And we'll talk about magnitudes on a different slide, just so you don't have to read them off the graph. This is looking at claims per patient, which is also a similar story. And this is looking at the average charge per claim. So what we're trying to get at here is like the average price per service. So is it that physicians are now, instead of billing for very high, costly services, billing for what might be more appropriately charged services? For example, if you ever go to your physician's office for a doctor, like a regular checkup, they have a choice of 5 codes they can bill. And they sort of range from both time and intensity. So there's like a 5-minute visit versus a 45-minute office visit. And this is sort of getting at, and of course the 45-minute visit is going to reimburse higher than a 5-minute visit. So this is getting at, are they billing more of these like 45-minute visits relative to these 5 minutes visits or not? That's just an example of sort of what's going on here. So it seems like prices, this is noisier, but it seems like the average price of the service that they're billing for is also falling. Okay, so like when you think about total, it's going to be, total charges is some composition of like the price per service times the number of services, right, times like sort of number of patients. And so this is one component that's also falling. Now if you look at patients per physician, it seems like there's the number of patients per physician is also dropping over time. And this is the only graph that has the blue line also declining. All the other graphs of the blue line fairly flat. And so, it seems like patients are either, we can't tell if the patients are leaving or the patients are just, the fraudulent billing for patients are falling. So we can't, in the same way that we can't verify whether a claim actually happened or not, we can't tell whether this is an effect of a decline in patients or a decline in billing practices, or a change in billing practices. But what it seems like is patients are decreasing. I think I would argue that because the 50th to 75th percentile is also changing, that it's actually reflecting an actual change as opposed to just a change in billing practices, which you would expect amongst the high 75th percentile providers, but maybe not the 50th to 75th percentile. Yes?
Isn't this inconsistent with the narrative that you suggested that basically the inline providers, the A and B guy, are going to be absorbing some of the new patients by it's not just different from 0, but the trend seems to be slightly down. When you kind of expect that to be significant and kind of above 0?
So it depends. You could still have it, like if the aggregate number of patients are falling over time, you could still have a shuffling of distribution within the organization, right? It would be a clearer story, of course, if one of the lines had an increase in patient counts. But I think what's going on here, and I looked at this a while ago, though I never made it to this version of this presentation, is looking at what happens to the beneficiaries, essentially patients within these excluded providers. When I looked at this a while ago with a completely different version of this paper, where we're looking at not the probability of exclusion, but really like pair effects and network effects, and identifying that as sort of the mechanism. So the results may be very different, mind you. It seemed like the beneficiaries were essentially patients were using less healthcare services, in particular amongst the things that seem to be more elective as opposed to more necessary. So I think that's one argument that can be made. But as I'll end up showing you more evidence about the patients, and I think it's still unclear exactly what's going on with the patients, whether they're leaving or whether they're just using less healthcare services. Do I see another hand?
I was just gonna ask if are your long run leads and lags actual like long runs, like you've dummied for years earlier than 4 and longer than 2?
Yes, I have, yeah, and great question, yeah. So I knew exactly, dummied for because we have such a long panel of data from 2002 to 2014, so anything prior to year 4 and anything after year 2 has a dummy.
I kind of ask because it looks, I mean, if you squint your eyes, a lot of the high probability, the fraudulent people, like you seem to see like a sort of spike in most of your measures. Like so like that one's like kind of small, but like some of the earlier ones, like that one, you know, that one a little bit too. Like, do you see what I mean? Like there's kind of like an uptick, and I was concerned that it was due to your reference group not actually being your reference group.
I see.
But it still is intriguing to me. And I don't know if it's an identification challenge. I don't think so, but it seems to suggest maybe that the sort of treatment is not quite as exogenous, maybe, as you led with. You know what I mean?
I mean, I think you can make that argument. I will show you that the aggregate coefficient is not statistically significant for most of these. Whether it's like a one-off or a trend type of thing is up for interpretation, I think. I'll also show you a graph where we use an even earlier window of predicted probability, so then it allows for an even wider range, and some of those things end up smoothing out. So that makes me think that it's not artificial, but yeah.
And that's always the challenge with, like, Ryan and I talked about this, like this is the challenge of these event study frameworks, is your sort of like gotcha plots are largely functions of what your reference year is, and like it can sort of change what things look like. I mean, your results are stark enough that your story's going to hold no matter what your sort of reference year is.
Yeah.
But it's still like this kind of unsatisfying consequence of these event studies.
Yeah, I mean, I've always been in the mindset that like if you pick an early enough reference year, it shouldn't matter and that you're just tracing out most of the trend. But yeah. I am. The reason I am thinking a little bit is I presented a version of this paper where I included substance abuse providers in here, which is why sometimes in the paper you might see a vestige of like substance abuse in there, which is no longer in these results. In fact, these results are all updated from the ones in the paper, and I think the ones in the paper are smoother than the ones here. And so like in that sense, like I'm not sure if it's a data problem or not, because with the substance abuse essentially allows for additional exclusions to help with the predicted probabilities. In which case they might have done a better job at sort of predicting these probabilities and smoothing out some of these lines, but yeah. Okay. All right, so getting to the magnitudes of what we're finding, to save you from looking at a whole bunch of coefficients, I just calculated percent changes for you, so looking at the coefficient relative to the mean. And I've aggregated these categories to like pre-years 2 and 4 to pre-years 0 and 2, which is essentially when we think of like plausible indictment, to post-years 0 and 2, which is, you know, after exclusion, the 2 years after exclusion. And then I've included the dependent variable mean. So if you look at this, it seems like, you know, and this is for the less than, I've also aggregated it to sort of the less than 75th percentile and the greater than 75th percentile. And it seems like there's like sort of the positive effects on the less than 75th percentile are statistically significant. They're non-trivial, though they're smaller than the deterrence effects that we measure. The pre-period here, like I mentioned, seems there's sort of a couple of these that are statistically significant, but for the most part not, and that's true also for the greater than 75th percentile. I think what we can conclude from this is, for the guys who are not fraudulent, what we see is increases, small increases in total charges and charges per patient. There is an increase in the number of patients, but it's not statistically significant, so likely zero. Much of this is being stemmed from the fact that they're doing more per patient that comes in. However, and there's really no change in the price per claim, which I find somewhat comforting. So it's not like they're like changing what services that they're providing. They're just sort of providing as the patient may need. For the greater than 75th percentile is where you see much of these effects, and the effects are larger for the post-exclusion period most of the time, if not consistent with the pre-exclusion period, essentially period of indictment or plausible indictment. And so what you see here is sort of effect sizes of sort of 6 to almost 12% reduction in total charges, 6 to 8% reduction in charges per patient, 3 to 5% reduction in sort of the price, and sort of 3% or so reduction in claims and claims per patient, and then a drop in number of patients following exclusion of about 4%. Right, so, and these are, I think, quite meaningful, and they're being driven really by that tail of providers where we think they're likely to be fraudulent. So like if you look at not just the 75th percentile, but you look at the 75th percentile relative to the 90th percentile, it seems like all of the changes are occurring really from the 90th percentile providers. So that's what I've shown here, 75 to 90 on the top and 90 and above on the bottom. And you can see that the magnitudes are all not much, but they're bigger depending on which columns you're looking at. The magnitudes are bigger for the 90th percentile. Yeah.
So when I was looking at the coefficient plots for the event studies and
Yeah.
looking at the table of means, so the coefficient plots are showing these kind of big, kind of within physician drops in all of these practices. But trying to compare kind of the pre-period means, is it the case that basically you have these, likely fraudulent physicians, and then there's the indictment, and as they cut down, they end up just looking like the non-fraudulent physicians, like in terms of the averages? Like so some of these, when you compare kind of the dependent variable mean and like the marginal effects to make like one group kind of look like the other, is that basically what happens? Is that once the fraudulent physicians are kind of behaving, then their averages basically look the same as all the other groups?
I should know the answer to that. I mean, one could do the math for that, like actually quite quickly. What is that?
I was looking at some of them look like they check out, but some of them still, like even with the big within physician drop, are still higher than the average for the less than 75th percentile.
That's right.
But with such a low probability of getting caught, like you'd expect their sort of expected discounted probability, like costs of fraud, to still be, I don't know.
Well, I think for me it's just a matter of, I'm just trying to like mentally kind of scale these within changes based on where they are kind of relative to the get-go.
Everyone else. That's definitely calculable, and I think interesting to look at. I think, and it sort of doesn't really matter what the answer is, whether it's sort of that they are close to or the same. It would be alarming if they did even less, and that I think then you could start to argue that there's sort of detrimental effects, maybe that they've overcompensated. But it would be a really good exercise to do. Thanks. Okay. We've done a series of sensitivity analyses to make sure that this is plausibly conclusive. So we've thought about regression to the mean, which is sort of the argument that, well, like if you pick the guys who look like they're just doing a lot, they're going to eventually look like they're doing less, and the guys who are doing less are going to eventually look like they're doing more. So that's just statistically true, and maybe we're not measuring anything. So we've used essentially the earlier years of predicted probability to try to see if we see changes earlier. So if it really was regression to the mean and we used years 4 and 5 for prediction, then we would start to see drops not within year 2, but within year like 4 or 3. We also did random assignments of dates to try to play around to see if this date is really plausibly exogenous, and we find essentially null effects when we randomly assign dates of exclusion. And then we've done some evidence around whether this is actually indictment or not, though I must say that it needs a bit of work. So I'll show you what we have. Okay, so this is essentially looking at charges and claims using the 4 to 5 year pre-period window. So I think that uptake that you had mentioned, you see it. It depends on how you want to argue it. I mean, none of these are statistically significant, at least the red bars. So whether or not there is a trend line or not, I think is up for debate. Because they're not statistically significant, and same with the total claims, we tend to think that it's not like an artificial effect that we're finding. And again, the effects don't really start until sort of years 2 or 3. I think that's more clear here. So the red lines and the blue lines essentially track each other fairly well. And that's essentially our conclusion. So whether you predict using the windows 3 to 4 or predict using the windows 4 to 5, they end up showing similar results. Random assignment of dates, you can see there are no stars, and which sort of leads us to suggest, and the effect magnitudes are kind of all over the place. These are coefficients that I've reported, so that's why they look big. But sort of we find no impacts here. And evidence around indictment, this is what we have so far based on our limited collection of data. So like we've essentially scoured the website for 2 years of data, and we are continuing to scour the website. So this is essentially what we have here is within the 75th percentile, these categories are continued on whatever was defined prior. So we use our entire sample to find those 75th percentiles. There's only 90 physicians in this sample of like non-excluded providers. So we're talking about small sample sizes, but we seem to, if you look at total charges, this lines up with this exact date of indictment, which is essentially now our year 0. And total claims looks 0, and you could even argue that the red line's going up, though everything's sort of statistically insignificant. So I think that with more data, some of this is going to get sorted out, and that's sort of what we're going to work on. Okay. I think for the remainder of the time, I want to talk a little bit about sort of getting into the details of what might be going on with these responses, who's responding, and sort of possibly what's going on. And so we do a series of sort of heterogeneity subgroup responses. So looking at whether the exclusion was permissive or mandatory. Permissive essentially is going to correspond to your misdemeanor conviction. So sometimes the Office of Inspector General, you can exclude these guys, but you don't have to. So it's up to them to decide whether the misdemeanor convictions will be excluded. Mandatory is essentially your felony convictions. You're automatically excluded. And it seems like there's arguably a larger response with maybe the mandatory exclusions. We've looked at differences between types of exclusions, so fraudulent providers versus the health crime providers. And there's no real difference there in terms of magnitudes of effect. I think what is arguably the most interesting is looking at organization size. And so we've essentially broken down the organization size into terciles. So this is not randomly chosen numbers. 41 is sort of like the first, less than 41 is the first tercile of physicians in an organization. It marks the first tercile. 41 to 156 marks the sort of the second tercile of organization size, and greater than 156. And it seems like marks the third tercile, and it seems like the largest effects are occurring for the larger organization sizes. Hospitals look like they're responding. Maybe there's more deterrence effects in hospitals relative to office, though the magnitudes aren't really all that different. Looking at the types of physicians in the subsample, so this is looking at general practice physicians versus your psychiatry physicians, which remember are those who are the ones with the highest likelihood of excluded probabilities, versus your hospital-based guys, which is essentially emergency room, emergency medicine, radiology, anesthesiology, pathology, and your non-surgical specialties, which is like cardiology, ophthalmology, etc., versus your surgical specialties, right? So like we've broken it down to sort of general classifications. And this, I think, also is interesting and sort of lines up with my intuition of the organization size, is sort of this idea that the hospital-based non-surgical specialties are the ones with the largest responses in effect sizes. So mind you, this is not just a matter of magnitude, right? It's not just a matter of like, oh, they reduced charges. It's the percent changes are actually larger. So one could have argued that, well, hospital, non-surgical, and surgical specialties bill more and higher on average, but so we're looking already at the percent changes. So, maybe more amongst hospital-based groups, which suggests maybe some sort of organizational response as opposed to individual response. And just looking at services, this is also broken up into major groups of services, looking at evaluation and management, essentially is like your checkup visit, versus major procedures, which is like major surgeries, minor procedures, which are like elective surgeries, imaging and lab tests. So imaging and lab tests are what people usually go to talk about wasteful care. So apparently the US does way more radiology scans, MRI scans than most countries. And it seems like the largest charge reductions come from those two service groups. We don't see it with the claims. I think part of this is being driven by the fact that not every provider provides imaging and lab tests. And so maybe that's sort of mixing with the sort of the smaller reduction in claims. The part of this, I think, is also driven by like specific services within imaging and specific services in lab tests. And I think we can do a bit more to refine like specific codes of services. Okay, this is what I wanted to get to on sort of, well, like what do we think is the dynamics of what's going on. So everything that I've talked about so far is looking at within organization effects. And it's possible that there's actually larger spillover effects so far we've looked at within the zip code. So this is now looking at responses by people in the zip code. I'm happy that that's flatter than the other one. So looking at charges and claims, I think you can conclude that there's similar responses. Sometimes it's noisier. So in particular claims, like the green line and the blue line somewhat flip, and although I think most of these are zero anyway, with very large error bars. But I think that like in general, you can, at least with the charges, assume that there's sort of a larger effect that's going on outside of just the organization. Yeah.
Do you have a sense of like how well this information is dispersed across providers, like within a zip code, or especially by size? Do you think there'd be probably better information dispersion as a larger provider versus a smaller?
We have not done this by provider size. And by that, I mean we haven't looked at this based on whether the excluded provider is part of a larger organization versus a smaller organization. I think it's definitely possible that like the sort of the prominence of the organization matters.
Even rural versus like urban counties too.
Rural versus urban would be interesting to look at. Though I guess you would expect there are not that many other providers in a rural area.
Yeah, so who's the information going to?
Yeah, so there's that. Though, and it's unclear how much information spreads in a rural area, so I think that sort of is hard to disentangle whether it's like an information spread story or just the fact that there's not that many providers. Yeah, I think we can try to figure it out. My understanding is that the Department of Justice releases some information about this. If you pay attention to the news, you'll know about it. There may be also some sort of word of mouth peer effect that might be going on. I mentioned to some of you guys, we did a version of this paper looking at seeing if this actually travels through peer effects. And we found results that aren't as stark as the ones here. And the peer effects were essentially defined by like physicians sharing patients. So you were considered part of a physician's network if you shared patients with that network. And so maybe that's another mechanism of how this is working. We eventually skipped that because I think it's hard to it was hard to convince myself that like an ophthalmologist and a cardiologist who shared a patient would actually ever talk to each other. So it's something that we can explore. Yeah.
What,
Yep.
what's the like average number of organizations within a zip?
Within a zip code, also a good question. I don't have the answer off the top of my head. There's oftentimes only one major hospital in a zip code, but as you've seen that most of these, like if you look at the distribution of organization sizes, most of these are like smaller organizations, and in that sense that we expect that there's quite a few like physician practices, solo or two physician practices, smaller practices, yeah. This is looking at the number of patients in organizations in the zip code. And I did the overall effect here, and I can show you the percentile and specialty effects. I just thought the overall effect was cleaner to look at, and you do see a drop here too. And so clearly the patients who used to go to an excluded providers organization are not going to other organizations in the zip code, which I alluded to earlier. Where they're going, I don't know if anywhere, right? So it might be that they're actually not going anywhere. It might also be that they were never real patients anyway to start with, and so in that sense, like it's not even a puzzle. What we plan to do is sort of expand this to larger geographic areas to see if maybe the patients are going to say outside of the hospital. Then we can expand it to a market area, essentially a hospital region, and see if that's still the case. I think, so essentially if you want to do some back of the envelope calculations to estimate exactly what is the impact of this deterrence effect, we know that the top 75th percentile of charges fell by sort of 6 to 12%. Keep in mind that we have 20% claims data, so then we take essentially our charges and inflate them to 100%, as if we had 100% claims. So the average quarterly cost is essentially the average quarterly charges is about $10,000 in the 20% sample, and if you inflate that to the 100% sample, that would be about $194,000, which corresponds to savings of like $12,000 to $23,000. So just multiplying these percentages with this number, it's about $12,000 to $23,000 of savings per physician. And then if you look at the number of excluded physicians, number of physicians sort of in that top 75th percentile, so we take the number of observations that we have in the top 75th percentile of organizations with an excluded provider, inflate that again by 20%, given the fact that we have 20% sample trying to move to 100%, that's about 80,000 physicians. To give you a sense, it's actually still a small share in the U.S. There's actually slightly more than 1 million physicians. It's still a small group, 80,000 relative to 1 million. And you multiply these numbers together, 80,000 and these savings dollars, and you get roughly about $1 to $2 billion of savings. Relative to the deterrence effect that we mentioned in the beginning, which is essentially the first I think the first slide I mentioned, the DOJ reports like sort of $2.7 billion in recovery. This is an additional sort of $2 billion of savings that results just from deterrence alone. So in conclusion, we find that there are strong deterrence effects, particularly among larger organizations and hospital-based specialties. There's a small drop in patients of about sort of 3%, and we see similar responses outside of the organization within the same zip code that sort of are in the magnitude of $1 to $2 billion. And this is sort of very much still work in progress, and I think we're going to work on getting those dates of indictment and expanding that sample size. Hopefully I've managed to convince you that it really is the date of indictment, and if not, I would love to hear now before I submit this paper. Considering sort of patient responses, I think we're also trying to think about physician sorting, which is a different question, but I think one that can also be answered with our data. So like, do the bad physicians sort to bad firms? Do the good physicians go to good firms? And then explore the opioid-related incidences. So that's all I have. Thanks so much for your comments.
Any last questions? Otherwise, Alice will be around for a little bit if you don't chat with her. Thanks so much for coming. So of course, we're not going to have a CHEP seminar on Thanksgiving. We will, I try. We'll meet again in 2 weeks when David Bradford from the University of Georgia will be joining us on an opioid-related topic, actually. So thanks very much for being here. Thanks, Alice, and see you next time. Have a good holiday.